everybody is muted, keeps their microphones on mute, and particularly whilst all of the speakers are giving their presentations, please. And can I ask the panelists and the members of the Caribbean Links team that if there is any inappropriate behaviour or comments that you see in the box, please flag this up so that we can sort of remove these people from the event. Throughout the event as well, we will be putting up our social media handles, both BCDD and Caribbean Links, so that you can kind of follow us in terms of other events that we'll be putting on in the future. So thank you very much.
And if it's okay, I am now going to ask our other amazing team member, Isaac, if he could please introduce Dr. Stacey.
Hello. I have the pleasure of introducing Stacey. So Dr. Stacey Bryan is an obstetrics gynecology registrar with an interest in surgical management of women's cancers. She obtained her undergraduate degrees in biomedical science and medicine at St. George's University of London in 2008. In 2015, she obtained membership to the Royal College of Obstetricians and Gynecologists. She's currently undertaking a Doctor of Medicine degree, an MD, at the University College London at the Institute for Women's Health, where her research is looking into the prevention and early detection of cervical cancers. Stacey is an advocate for health awareness and literacy in the community. She is the Vice Chair of the British Caribbean Doctors and Dentists Association, has featured on the Birth Booth podcast, and has worked with charities such as Bloody Good Period and London in Your Language to provide education surrounding women's health to those marginalised in society. Stacey, please do take it away.
Thank you very much, Isaac. I'm just going to share my screen. So welcome again, everyone. I hope you can all see that. So I just thought I'd start by talking about NHS screening programs that are available. It's all good sort of learning about diseases and treating it, but we really want to move a drive toward prevention and early detection of diseases so that we can pick that up easily and quickly. So what is screening? Screening is a way of identifying apparently healthy people who may be at increased risk of health conditions. So there's many different diseases that can be screened for throughout our lives. And the way that I'll break this down is based on age or stages within our lives and what screening may be offered at each stage. So the first screening that may be offered is usually screening in pregnancy. So all pregnant women are offered screening for HIV, hepatitis B and syphilis, and that's by 10 weeks of their pregnancy. And this is because not only do we need to treat women who are found to have these diseases in their pregnancy, but there is a risk of passing that on to baby. HIV, obviously, there are medications, very good medications that can be used to reduce the viral load and then therefore reduce the risk of transmission to baby. Hepatitis B, again, important to treat mother, but also baby would need vaccinations after delivery, and syphilis you can treat with antibiotics. The other element of the screening program in pregnancy is that of genetic abnormalities within the baby. So things such as Down syndrome, Edwards syndrome, and Patau syndrome. So these are also known as the trisomies. And this is basically when you have 3 copies of a gene instead of 2. Now, babies who are born with Edwards and Patau syndrome, unfortunately, do not live much long after birth. Of course, we know babies with Down syndrome do, but there are sort of complicated health issues that these children do have. So by screening via a blood test between 10 to 14 weeks, you can give an idea of whether the pregnancy is at a high risk of any of these trisomies. Now, it doesn't diagnose this in the pregnancy, it just suggests that now you may have a higher risk and therefore more testing needs to be done. As I said, that's usually done by a blood test between 10 to 14 weeks. Another blood test that we do is for sickle cell disease and thalassemia. Now, if a mother is found to be a carrier of sickle cell disease, for example, then the baby's father is then tested, and then it will be a case of discussions as to what the risks are to baby developing that. So all of these tests are usually done by the booking appointment. So this is when you find out that you're pregnant and see a GP and the pregnancy is booked, certainly all before 10 weeks, and they can be done in the same blood test. The other part of screening in pregnancy is for physical abnormalities. So this is known as the 20-week scan. It's usually done between 18 and 21 weeks. And this is looking at structural features of the baby. So baby's face, baby's spine, the brain, the kidneys, the bones, and again, just looking at if there are any abnormalities. And the reason behind screening is that it kind of gives an informed decision and choices to the woman as to whether she continues on with pregnancies, if there are any abnormalities detected, and if she does continue, what help will be needed after baby is born. The next stage of screening that we may encounter is screening for newborn babies. So all newborn babies are offered a physical examination within 72 hours of being born, and that's sort of a top to toe examination, having a listen to the heart for any murmurs. And also some babies are born with some congenital issues of the hip, so they check that as well. Of course, with babies, any abnormalities in physical examination can slow development as well, so it's important that they're examined and these things are picked up as soon as possible. Likewise, a hearing test is performed soon after birth. So this is where a soft electrode is put into the ear. It plays little vibrations, and then they record the vibrations that are coming back from the ear of the baby. And about 1 to 2 in 1,000 babies actually have some hearing difficulty soon after birth, and that's despite the parents having absolutely normal hearing. So again, why we do a hearing screening. And then the blood spot test, also known as the heel prick test, is done at day 5. And this usually looks for cystic fibrosis, sickle cell disease, hypothyroidism, and a few other kind of metabolic conditions. Again, it's about picking these up early and treating babies so that they can improve in terms of their development. The next screening you may encounter is cervical screening. Now, this is close to my heart because my research has been on cervix cancers. So all women aged between 25 to 64 are invited for cervical cancer screening. Between the ages of 25 to 49, you're invited every 3 years, and between the ages of 50 to 64, you're invited every 5 years. Now, they do say that Black women in particular are sort of lower uptake for cervical screening. But I just kind of want to go through what it actually involves. So it's usually performed by the GP surgery, either by the doctor themselves or more commonly by the practice nurse. It's about a sort of 10-15 minute appointment, but the procedure itself is very quick. You'd be asked to undress from the waist downwards, lie on a couch, and then they use a speculum, which is a tool which is inserted into the vagina, which helps us look at the cervix, which is the neck of the womb. And then a soft brush is used just to take some cells from the cervix, and that's sent off to the lab. And what they look for in that test is what we call HPV. So HPV, or human papillomavirus, is the virus that we know is responsible for over 99% of cervical abnormalities and cervix cancers. About 80%, so majority of women, or 8 out of 10 women, will have had HPV at some point in their lives, but the majority will clear that infection, providing that they have a good immune system. So things like smoking, which stops your immune system from working as efficiently, will put you at increased risk of changes to the cervix. So we often advise women to stop smoking if we do see some abnormalities on the cervix. So as I said, it's sent off for HPV testing. If you're found to be HPV positive, they then look at the cells on the cervix, and if there are any abnormal cells on the cervix, you'd be invited in for colposcopy, and this is hospital-based. And it's a way of looking at the cervix a little bit more clearly, and if there are any abnormalities that we can see, we'll take a biopsy or we do treatment to remove the abnormal cells. Now, the really good thing about the cervical screening program is that the time from HPV infection to developing cervical cancer is about 15-20 years. So actually, if this is picked up quite early and is treated, it definitely does reduce your risk. of developing a cervix cancer. And even if there is a small cancer that's detected on a biopsy, sometimes that treatment in hospital is all that's needed, rather than, you know, the cancer progressing further and then therefore needing hysterectomies and things like that. So I'd really strongly advise for women who are invited for the cervical cancer screening to please attend it. So diabetic eye screening is the next sort of screening that's offered on the NHS. I won't say much because I think Emma may be talking about it in her talk, but basically all diabetic patients from the age of 12 are offered a diabetic eye test every year. Of course, need to mention breast screening. So breast screening is offered to women aged 50 to 70, and the idea is to detect breast cancer early. It's offered every 3 years. And the way it's done is via a mammogram. So when you're invited for the screening, an X-ray is taken of both of the breasts. And if there are any lumps or abnormalities or shadows that are seen, then you may be invited in for an ultrasound scan and a biopsy. And then that determines whether more treatment or not is needed. If you're over the age of 70, you can actually self-refer for this screening. And yes, those under the age of 50, unless they have any family history or genetic mutations which mean that they have to have regular breast screening, they aren't necessarily invited for breast screening. But what I would say is for women to kind of get used to examining your breasts, and the best time to do it for those who are still having periods is after your period rather than before, because before or during your period the breast can feel quite lumpy anyway. So it's important that after your period, get used to once a month just examining your breast, examining the armpit, and just making sure you can't feel any abnormal lumps or bumps, and if you do, to see the GP to be referred in for further tests. So far seem to have left out the men, but no, bowel cancer screening is available to men and women between the ages of 60 to 74. It's now done by a home testing kit, so the kit is posted out to you, also known as a FIT kit, and it's done every 2 years. Essentially in the kit, you have a tray in which you collect your stool, your poo, and then there's a bottle with a stick within the lid, and you run the stick through the stool and then you pop that into the bottle and that's sent off. Again, it takes about 2 weeks to come back. And what they look for in the testing is there any presence of any blood. And if there is some blood, it doesn't necessarily mean you have cancer, it just means that there's further investigation that needs to be done. And usually that investigation is via an endoscopy or a colonoscopy, which is a camera looking into the back passage. And you may at that time see some polyps, which are overgrowths within the intestines, which can be removed and sent away. In some parts of England, this endoscopy or colonoscopy is offered to men and women aged 55 years. Abdominal aortic aneurysm, so the aorta is a large and major blood vessel which runs from the heart down the middle of the body. Some people have a greater propensity to swelling of the aorta, and they can either have a small, medium, or a large swelling. The screening is done by an ultrasound scan, and it's usually offered to men only over the age of 65 because these tend to be the higher risk group. If they have a scan and the size of the aorta or the swelling of the aorta is within normal limits, then no further screening is needed. If there is a mild swelling, then they're often screened every 2 years. If there's a moderate swelling, it's every 3 months. And if there is quite a large swelling, then you're referred on within 2 weeks for surgery. The worry about the swelling of the aorta is that it can burst suddenly and obviously cause quite catastrophic bleeding. So those are the NHS screening programs that are available, but I thought I would also just mention prostate cancer. Very important because Black men have a higher risk of 1 in 4 Black men develop prostate cancer within their lifetime compared to 1 in 8 in other ethnic groups. There is no formal screening program, but men over the age of 50 can ask their GP for a PSA test, which is the prostate specific antigen. The only problem with the PSA test is that it can be elevated in a number of other conditions, not just prostate cancer. And that's part of the reason why there is no real screening program. So an infection, A urine infection or inflammation with the prostate, for example, can give a falsely raised or a raised PSA, which doesn't necessarily mean that it's cancer. There is a research program ongoing at the moment at the Institute of Cancer Research, which is looking into why Black men have a higher risk. Is there some sort of genetic factors? Because up until now, there's no kind of clear answer as to why. What we would advise is that if you do have any problems, and in particular with passing urine, so either going too frequently or feeling like your bladder is not fully emptying, then to see your GP. And what the GP may do is a rectal examination, because they're able to feel the prostate via the back passage and see if it's irregular or not. And then they may refer you on for an MRI scan, so a more detailed scan, and a biopsy may be taken. So before I go on to kind of lifestyle changes, just to sort of let you know that in terms with all of the screening program, as you said, it's about picking up disease early and treating it early so it doesn't progress onto anything more serious or sinister. And I know some people may be worried, well, why would I go for a test when I feel absolutely fine and healthy, to go somewhere and there's someone to tell me that I've got something? I would say that the majority of people who go for screening, sort of 80 to 90%, will all have normal results. It's just that small sort of 10% or so that you need further investigations. And as I said, it's always best to pick things up earlier, where it can be treated quite quickly. And oftentimes you can be cured if it even is a small cancer, rather than leaving things alone and letting it progress. So I just mentioned a slide about lifestyle changes, but I don't want to take away from our nutritionist talk. But essentially, again, it's all about promoting good health and preventing all of these problems in the first place. And the common theme behind breast cancer, colon cancers, cervix cancers, all of these cancers, is that your risk is increased if you smoke, if you drink alcohol, if you're overweight, if you don't exercise, if you're not watching what you eat. So just general lifestyle changes in cutting down all of these things will help to kind of prevent ill health, essentially. And then I'll just leave you with this quote by James Baldwin. So not everything that is faced can be changed, but nothing can be changed until it is faced. Thank you very much.
That was wonderful, Stacey. Thank you so much. Could everyone give her a big applause, please? Because that was absolutely fantastic. If you do have any questions, please do obviously pop them in the chat box so that they can be answered in the relevant Q&A section at the end of the event. So I would now like to introduce our next guest speaker. That's Dr. Emma Blake. So Dr. Emma Blake is a GP registrar working in Southwest London. She obtained her medical degree from King's College London and also received a Bachelor of Science degree in Regenerative Medicine and Innovation Technology. Dr. Blake is also a member of the British Caribbean Doctors and Dentists Association and leads its health promotion team with the aim of promoting health, raising awareness and reducing morbidity and mortality within the Caribbean and Black British community. Dr. Blake has a passion to help students fulfill their potential. She has a special interest in demystifying science through interactive science tuition, mentoring and coaching. Dr. Blake is also the founder of the social enterprise Student Success Formula, which offers high quality online science tuition to students aged 11 to 16, as well as running free events to parents and students from BAME backgrounds with essential tools needed to excel within the UK education system. Dr. Blake, please take it away.
Hi, good evening, everyone. Welcome. So I'll be talking about diabetes this evening. I think it's very important that we explain this topic, understand it, and know how we can manage it and also prevent it if we don't already have the diagnosis. Okay. If you have any questions, please do type them in the chat and we will be going through the questions at the end during the Q&A section. Okay. So I think this quote is quite important to highlight why we need to raise awareness about diabetes within our community. So the Diabetes in BME Communities Working Group said that in Black African and Black African Caribbean communities, diabetes is up to 5 times more prevalent than in people of white European origin, okay? So that highlights our need to know why is it more prevalent in our communities and what can we do about it. Also, they said that up to 20% of the South Asian community and 17% of people from Black and ethnic groups living in the UK have type 2 diabetes, in contrast with 3% of the general population. And I think just to expand on that, you know, we know about COVID-19, and we know that that's a pandemic, but diabetes is also a pandemic. It's a disease that has affected the whole world, okay? Around the world, there's probably about 450 million people with diabetes, and in the UK there's around 4 million people with diabetes, and the percentage of our population around the world globally with diabetes is about 9.3%. So almost 10% of the global population has diabetes, some kind of diabetes, and in the UK it's a little bit better. About 6% of our population in the UK has diabetes. So it's important for us to know what is diabetes, what complications can it cause, and then if we realize that Black and South Asian communities are disproportionately affected by diabetes and have a higher prevalence, then we need to understand why and see how we can minimize our risk of developing diabetes or better manage it if we already have a diagnosis of diabetes. So in this brief talk, I'll be covering the following. I'll be explaining what is diabetes. I'll also look at some of the symptoms and signs that we can look out for. I'll talk briefly about how it is diagnosed. We'll look at some of the complications of diabetes, the types of diabetes. We'll cover diabetes emergencies, especially for those who have a diagnosis of diabetes or have a family member who has a diagnosis of diabetes, and we need to know what to look for if something were to go wrong very quickly. Also, we'll talk about some of the risk factors for diabetes and how we can manage a diagnosis of diabetes if we have that diagnosis, how we can potentially reverse diabetes, which is known as diabetes remission, and that's only in certain types of diabetes. And then finally, how we can prevent the development of diabetes. Okay. So what is diabetes? Essentially, diabetes covers a range of different types, okay? But it ultimately, in all of the different types of diabetes, there is a high level of glucose in the blood. So we know that in our bloodstream, in our blood vessels, we have red blood cells that are flowing around our blood vessels. But in addition, we have different salts within the plasma of our blood. And when there's too much glucose in our blood, that's one of the key features of diabetes, too much glucose. So we know that we get glucose, which is a type of sugar, from the breakdown of carbohydrates. So when we eat food and we digest the food, particularly carbohydrates, they are broken down into smaller molecules, and the smaller molecule of carbohydrate would be glucose. And so the beautiful thing about our bodies is that we have regulatory systems that help to balance the different levels of hormones and substances within our body. So glucose also has its own, what we call homeostasis. Our body has a homeostasis or regulatory mechanism to make sure that the level of glucose in our blood is not too high and not too low. So in somebody who is not diabetic, our body produces a hormone called insulin that helps to regulate the level of glucose in our blood. And normally what happens is the hormone insulin targets the different cells in our body, so our muscle cells, our fat cells, and it promotes those cells to take up the glucose which is circulating in our bloodstream. Unfortunately, in patients who have a diagnosis of diabetes, that system, that regulatory system, doesn't work very well. And so that results in there being too much glucose in the bloodstream. Now, glucose is a good thing in that it can give us energy, but when there's too high a level of glucose in the blood, there can be some complications and side effects of this, which I'll go on to explain. So I hope that makes sense. Essentially, diabetes is having too much glucose in the blood because for whatever reason, our bodies are not able to regulate that process in the normal way that it's built to do so. So there's some key features or reasons why this might happen. So either our body just does not produce any insulin, so no insulin is produced, which is a key feature of one type of insulin, so type 1, so key feature of one type of diabetes, sorry. And another mechanism is that our bodies might not respond to insulin effectively, often known as insulin resistance. So it might be that our body is producing insulin, but for whatever reason, the cells in our body that are supposed to respond to the insulin hormone and take up glucose, they're not as responsive. And so the glucose doesn't enter the cells and remains in the bloodstream. In addition to that, it just might be that the pancreas, which is the organ in our abdomen that produces the hormone insulin, might not be producing enough insulin. And so I won't go too much into the science of it, but there are specific cells within the pancreas called beta cells that produce the insulin. And in some types of diabetes, that beta cell, the numbers of beta cells decrease, which results in less insulin being produced. So in both cases, whether it's the body produces no insulin because of complete destruction and loss of these beta cells, in that case, no insulin is produced and there's high levels of glucose. And in another scenario, and particularly in type 2 diabetes, two things may be going on. Our body might not be responding to the insulin as it should. And in addition, the body is not producing enough insulin because the beta cells are also being destroyed gradually over time. Okay, so what can diabetes lead to? So what's important to know is that, you know, with one type of diabetes, so type 1 diabetes specifically, often the onset of symptoms is very rapid and very quick. And for type 2 diabetes, the onset of symptoms can be quite gradual. But if for somebody who doesn't have a diagnosis of diabetes, they may experience a number of symptoms, and this is important to be aware of, so that you can kind of, if your family member says, oh, I've been peeing a lot more than usual, I'm feeling really thirsty, these are things that should be alarm bells and make us to start asking questions and encourage them to go and visit their GP and make an appointment. So one of the symptoms may be having to pass urine more often. Okay, there can be many reasons why somebody might need to pass urine more often, such as a urinary tract infection, etc. But in combination with some of the other symptoms, then it can point us more towards diabetes. Also, people may start to complain of feeling a lot more thirsty. People may feel a lot more tired. There may be weight loss. And it's interesting because those 4 symptoms, you can categorize them or remember them by using an acronym known as 4 T's. So thirst, thinning for weight loss, tiredness, and toilet, having to go to the toilet more. There are other symptoms as well. So if someone has lots of infections or are frequently getting infections, whether it be thrush in the mouth or the genitals, or they're having lots of urinary tract infections, or if someone has wounds but they're not healing as they should, they're taking a long time to heal, all of these can be a sign that there may be an undiagnosed diabetes. So how is diabetes diagnosed? So if somebody were to experience some of these symptoms and they went to their GP, and you know, the GP would take a history from you and find out what you're experiencing, how long it's been going on for. They'd probably want to find out if there's any family history of diabetes running in your family, any first degree relatives like your parents or siblings with diabetes. Then the GP might decide to do a blood test. So there's a blood test that is now commonly used to diagnose diabetes, and it's useful. It can be useful for many people, but there are some exclusions. This blood test is called HbA1c, and so that's a short name for it, or the short abbreviation for it. What it's looking at is the amount of glucose that is stuck to your blood. So our blood cells circulate in our body for between 2 to 3 months, and as I said before, the key feature of diabetes is too high a level of glucose in the blood. So the HbA1c looks at how much extra glucose is in your blood over this longer period of time, 2 to 3 months. So that blood test gives us a number, and diabetes is a continuum, so there's a range, but the blood test, what we've been able to do is have like a number that we can say this number would be diagnostic for diabetes. So the number that we give, you don't have to remember this, but it's 48. So if somebody has a HbA1c of 48 or above, then that would indicate a diagnosis of diabetes if they had symptoms with it, like the symptoms I mentioned before. If they didn't have any symptoms, but for whatever reason, the GP just did a blood test and that came back as a result of 48 or above, then the GP would most likely repeat the blood test. There are some people who HbA1c won't work for. So people with kidney problems, kidney impairment, or people who are taking steroid medications or other types of medications, a HbA1c blood test probably won't work for them. So the other ways that we can diagnose diabetes would be doing a simple glucose blood test, and looking at your fasting glucose blood test, and also looking at and basically also looking at a blood test where you haven't been fasting, and the GP can help to diagnose it that way. So once somebody has a diagnosis of diabetes, why do we even care about diabetes? Because the thing is, some people may not have symptoms. So there are many people, as I mentioned, who may have no symptoms. The type 2 diabetics may not have any symptoms for a long time. And even somebody who has been diagnosed with diabetes might not experience any of the symptoms we described a few slides before. But the reason why it's important for us to be very meticulous about looking after our bodies and making sure we manage diabetes well is because there are some long-term complications. Okay, so the long-term complications can be categorized into 2 groups. There are the long-term complications that affect the large vessels of the body, and there are also long-term complications that affect the small vessels of the body. So in medical jargon, we use the terms macrovascular complications and microvascular complications. So the complications that affect the large vessels of the body affect the vessels, for example, the heart, the vessels that supply the heart muscle. And so ultimately, diabetes results in extra inflammation and damage to the blood vessels. And so that can result in increased risk of heart attacks, can result in increased risk of strokes, both types of strokes, whether it's an ischemic stroke where the blood supply is cut off to an area of the brain and that area of the brain is starved of oxygen, or even hemorrhagic strokes, which is where there's a big bleed in the brain. Diabetes can increase the risk of both types of strokes. Also, diabetes also increase the risk of peripheral vascular disease. So many people in our community might know of a relative or a grandparent who had to have an amputation because they were diabetic and eventually died. Now, thankfully, if we manage our diabetes well, we can avoid those very sinister complications such as amputations. But it's important to be aware that poorly controlled diabetes or not being compliant with our medications can sadly result in some of these serious complications. It can increase the risk of heart attacks, strokes, and amputations, but these can be avoided, so that's the good news. And then the other category of complications, and these are long-term complications that can happen over time if diabetes is not managed well, involve the small vessels. Okay, so the small vessels that supply the eyes and the retina. So the retina is at the back of the eyes, and if you remember having your eye test, sometimes the optician or an ophthalmologist will use a fundoscope to look at the back of the eyes, and so they're looking at what we call the retina, and in the retina there is different areas of the eyes that help with our vision. So ultimately, diabetes, if not controlled well, can result in vision loss and blindness. There's different stages to this, and this can be prevented, but it's important that we are aware of this complication to avoid it. And so as Dr. Stacey alluded to earlier, diabetics are invited to have an annual retinal screening check. So if you are a diabetic, you should be sent a letter by the NHS inviting you to go to an eye screening clinic, and they will be looking at the back of your eyes to determine if there's any damage as a result of diabetes. And if you haven't had that, if you are a diabetic and you haven't been called to have that check within a year, then you need to contact your GP. And this is where we need to take ownership of our own health and go out there, speak to the GP and say, I haven't had this annual check, because it's important to check the back of your eyes to avoid this complication of sight loss. Also, diabetes can have an impact on our kidneys. It can result in high blood pressure and also result in end-stage renal failure, ultimately resulting in the need for dialysis or transplantation. And another thing to be aware of is that diabetes can affect our nervous system. So it can affect the peripheral nerves. So it can affect our sensation from our feet and our toes, where people with diabetes may experience loss of sensation or pins and needles in their legs from their feet going upwards. And also it can affect what is known as our autonomic nervous system. So some people with diabetes might experience erectile dysfunction or problems with controlling their urine, urinary incontinence. They may experience flushing after eating, or dizziness, or loss of blood pressure. So there's different effects of diabetes, but again, these long-term complications can be minimized, or we can try to prevent them through how we manage our diabetes. So again, positive news is that with the right treatment, diabetics can live a healthy life with less risk of complications. And I think it's important to know that, you know, for type 2 diabetics, 50% of the mortality rate or the death rate in type 2 diabetics is because of these complications, these the complications of the heart attacks, the strokes, and the peripheral vascular disease. So if we can treat our diabetes and manage it well, then we can avoid and minimize that risk of the complications and of death as well. Okay, so the three main types of diabetes, I alluded to them earlier. There's type 1 diabetes, there's type 2 diabetes, and there are other rarer types of diabetes. Those would include gestational diabetes, which can occur in pregnancy. So somebody who's not got a previous diagnosis of diabetes can develop diabetes in pregnancy, and that would resolve after they deliver the baby. And there's also another type of diabetes, very rare, a genetic type known as maturity onset diabetes in the young. Okay, so type 1 diabetes involves where our bodies do not produce any insulin. As I mentioned before, it's often rapid onset. We often see it in a younger age group. It's known to be autoimmune, so our body is almost fighting against itself in a sense, and there's destruction of those beta cells that produce the insulin. And interestingly, 1/3 of type 1 diabetics present with an emergency called diabetic ketoacidosis, so DKA, and I'll explain that in the next two slides about one of the emergencies we need to look out for. Type 2 diabetes is when our body may not respond to the insulin, and eventually also not enough insulin is produced. So type 2 diabetes makes up the majority of cases of diabetes. It often is gradual onset. Sometimes people have no symptoms. So if you notice you know, if there's a family history of diabetes and, you know, you may be on the larger side, if there's any symptoms that you notice at all, it is important to go to your GP and say, actually, I'd like to have a diabetes blood test. Type 2 diabetes involves a combination of genetic factors and environmental factors. And there is an association with obesity or central obesity around the abdomen. So in terms of emergencies, I'll talk about diabetic ketoacidosis. For short, we call it DKA. So this is an emergency, and some people who don't have a diagnosis of diabetes can present like this. So some people may have experienced blurred vision, confusion, and they may lose consciousness or have reduced consciousness. They may have abdominal pain, and they may have nausea, or they may start vomiting. This doesn't just occur in type 1 diabetics. It can occur in type 2 diabetics as well if they're experiencing some kind of stressful factor. So we call it physiologically, if their body's under stress. So for example, if they're having a major surgery, a type 2 diabetic could have DKA. And ultimately what happens is they have extremely dangerously high levels of glucose in their blood. Also, because of the high levels of glucose in their blood, they start passing lots of urine and they lose lots of the salts from their urine. So they lose these electrolytes, they become dehydrated. And also one of the processes in the body in breaking down the fats is that they have lots of ketones, something called ketones being produced. Their blood becomes acidic, and this can be life-threatening. So the treatment here, they would need to be rushed to hospital as an emergency and receive emergency treatment with intravenous fluids and insulin. Another emergency important for people who are known to be diabetic to be aware of is hypoglycemia. Okay, so this is when there's dangerously low levels of glucose in the blood. So this could be as a result of, you know, taking diabetes medications or taking insulin, and it might be too much and the glucose level goes too low, and this can lead to loss of consciousness and death. So whilst we want to treat diabetes well, GPs are also mindful that we don't want to make the HbA1c too low, because there is a risk that it can lead to hypoglycemia in our patients. So let's think about the risk factors, and I'm going to wind up here. The risk factors for developing diabetes. See here. So obesity is one of the main ones we're aware of. That obesity increases, also can be associated with increased fat around our organs, and also insulin resistance, so our body doesn't respond well to insulin. Also, ethnicity is a risk factor. So those from South Asian and Black African or Black Caribbean backgrounds also have an increased risk of diabetes. High blood pressure increases your risk of diabetes. A sedentary lifestyle, family history of diabetes, and age, so the older age group, also increases risk of diabetes. And 3 of these risk factors are modifiable, so we can do something about them. We can do something about obesity by losing weight. We can do something about high blood pressure by treating our high blood pressure through either diet, lifestyle, or medications. And we can do something about a sedentary lifestyle. Things that we can't do anything about is our ethnicity, our family history, and our age. Okay, so I'll just read this quote. So in 2012, the Southall and Brent Revisited study concluded that almost half of all people of South Asian, Black African, and Black Caribbean descent will develop diabetes by age 80. So they're saying that 1 in 2 people aged 80 from Black backgrounds will have diabetes. So there's things that we can do to try and minimize our risk of developing diabetes if we don't have it, and improving our diabetes and our overall health if we do have diabetes. So how can I manage my diabetes? So the key thing is education. It's important to know about diabetes, which is what we're doing today. But if you have a diagnosis of diabetes, or you've been diagnosed with pre-diabetes, so there's a range before you get diagnosed with diabetes where it's between 43 and 47. If you're told that you're pre-diabetes or borderline, then your GP can refer you to a pre-diabetes clinic where you can go on a course and learn about diabetes and how to prevent it. If you have been diagnosed with type 2 diabetes, there is also another course, I believe it's the Desmond course. I need to double check if it's Desmond or Daphne. There's two courses. There's a course for type 2 diabetes, and you can your GP can send you on that course where you can learn about how to manage your diabetes through diet and through medications. And if you have been diagnosed with type 1 diabetes, then there's also a course to teach you about how to use insulin and change your insulin doses. In addition, you can manage your diabetes through diet. So reducing the amount of saturated fat that you're taking in, that can improve your diabetes. Exercising, so physical activities. So studies have shown that physical activity of 30 minutes a day actually can help to manage and also prevent diabetes. Increasing fiber intake and also medication. So if diet and lifestyle changes have no impact, then obviously GPs will prescribe you a medication, possibly starting off with an oral tablet that you'll take, such as metformin is one example, and there's a whole range of tablets that can be used to treat diabetes. But also it may be if medication and tablets medication don't help, that you may need to be given insulin to inject subcutaneously. And also the key thing about managing our diabetes is that we need to take ownership and we need to be empowered of how to look after our health and have longevity. So there are annual checks. I mentioned the eye screening check, the retinal check. There are also annual foot checks to check if your sensation is still intact. These are things that if you know you've got diabetes, make sure you get these checks. If you put it in your diary, write it down, make sure that you prompt yourself to check with your GP if it hasn't happened yet. If you want to know about your kidney function and to avoid progression of kidney disease, then ask your GP to do a urine test that looks at the amount of albumin in your blood, and these are things you can speak to your GP about and say, I am diabetic, I want to have good control. When can I do my HbA1c blood test? These are things that should be done every year. And if your levels are high, your GP should be doing them more frequently, maybe every 6 months or even every 3 months. So the good news is, especially for type 2 diabetics, that there's a new body of research through a program called the DIRECT program, where they've been looking at how to help diabetics or type 2 diabetics go into remission. So where their HbA1c level, which was the diagnostic level of when they were classed as diabetic, comes into a normal range, and they no longer require any medications, any insulin, and their risk of complications is reduced. So they've been giving patients a low calorie diet with foods or shakes, and they've also that's resulted in the patients having weight loss, which has resulted in a reduction in the amount of fat around their liver and pancreas, and ultimately that has meant that these patients no longer need any medications. So there is hope that if you are a type 2 diabetic, there is hope to reverse the diabetes and bring yourself into remission. And there is research ongoing about this to see how they can use these methods to help people who are not overweight and have type 2 diabetes, and also to help different ethnic groups. And it's important to know that type 2 diabetics are not all obese. Some people are quite lean and still have type 2 diabetes. So there's a combination of, environmental factors and genetic factors as well. And finally, diabetes prevention. So if you don't have a diagnosis of diabetes, there are things we can do to prevent ourselves developing diabetes. So weight reduction is one of the ways we can help to prevent diabetes, increasing our physical activity, as I mentioned before, just as in how to manage our diabetes better through diet and lifestyle, reducing our amount of saturated fat in our diet, increasing fiber is important. That's been shown as a key factor in some studies. And for those who are in the pre-diabetes range, where the GP says you're borderline, there is an argument from some studies that giving metformin can help to prevent that patient becoming diabetic. So these are things that we can discuss with our GP if you're worried about any of these things. But I would also encourage you, there is a diabetes risk score, and I'd encourage all of you to go onto the diabetes.org.uk website or type in diabetes risk score, and there's a series of questions you can go through, and it can give you your risk of developing diabetes over a 10-year period. So low risk would be 1 in 100. So 1 person out of 100 people would develop diabetes over 10 years, and high risk would be 1 in 4 people would develop diabetes over 10 years. But have a look at that risk score and go through that, because that will help to direct you. And if you are high risk, then I'd encourage you to make an appointment with your GP. GPs are still seeing people at this time. You can probably have a telephone consultation and talk through your concerns about diabetes. If you are diabetic, discuss how you can better manage it, and just get on top of your screening programs and your annual checks, so that you are seeing your practice nurse for your diabetes checks regularly, and also having your eye screening and foot screens as well. Thank you.
Thank you, Dr. Blake. Can everyone give it up for her? That was absolutely fantastic. Like I did mention before, if you do have any questions, please do pop them in the chat box, so obviously we can have them answered at the end of the event. Now I've got to hand over to Afia.
Thank you so much, Isaac, and thank you so much to our panelists for their brilliant presentations. So much information, so much knowledge. Thank you. I'm now going to introduce our third panelist for this evening, Emeze. Emeze is a registered associate nutritionist with a master's degree in clinical nutrition, a diploma in counselling, and is the founder of the health consultancy's Life Recipe. With a background in product development, working with various global food brands, she understands how food can effectively support health and help us thrive. Now working in both private and public settings, she works with individuals and groups to cultivate a sustainable, healthy relationship with food to enhance health outcomes. Emeze has an Instagram page at lifes_recipe, LIFES_recipe, where she shares recipes and debunks nutrition myths to inspire you on your health journey. Wow, that is amazing. I'm now going to introduce the amazing Emeze. Please can we give a massive clap for Emeze?
Thank you all. So I just to note, I've just had some tech issues, so I will be, thank you Stacey for sharing the screen for me. So I'll be saying next slide, just so you know. Yeah, so thank you Afia for that. Yeah, my name is Emeze, I'm a clinical nutritionist. I've also been working with a few colleagues on developing culturally specific resources, which I'll also briefly touch on as well. And I will also be talking about health and nutrition within the Caribbean community. Okay, next slide. So as you've heard already, some of the key issues that disproportionately affect Afro-Caribbeans includes diabetes, high blood pressure, strokes, and this is not an exhaustive list. We've heard some other things as well. And issues such as type 2 diabetes, blood pressure and strokes, they are also largely influenced by diet and lifestyle factors. But not only, and you'll see this in the third column, not only is there limited data, but there's also limited resources tailored towards Caribbean origin populations. So myself and 2 of my colleagues, we carried out some research in the African Caribbean community a few months ago. and we'll hopefully have the report ready to share in the new year. But for now, we're just writing it up at the moment. Just next slide. So while I can't share much of the data from our report yet, one of the questions that was asked, which was quite interesting, was, have you ever received nutritional information or guidance from a healthcare practitioner, whether that's a GP, a nutritionist or dietitian? And it was quite sad to see that, considering that there is a disparity in health, a lot of the Black community were not receiving the lifestyle information or guidance that they needed. So it really did highlight to us that there is more to be done. Okay. So one resource that is available nationally is something called the Eat Well Guide. And this is a sort of guide of how we should ideally be eating throughout the day. But this resource in itself can sometimes create a barrier within the African Caribbean community. And a story that I always recall is I was given a talk predominantly to a Caribbean community of people who were living with diabetes. And I remember having this Eat Well guide up on the slide, and one lady stopped me and said, so are you saying to me that I need to switch all of the foods that I've been eating, because I don't see my foods up there? So do I need to stop eating my chocho, my yam, my pumpkin? And then everybody else was in agreement, and I could see that it was causing a lot more confusion and uneasiness than actual good. So I ended up scrapping this presentation and the Eat Well guide as well, and started talking to them based on the foods that they were accustomed to. So from that and from our research, we completed an Eat Well guide tailored to African and Caribbeans, which again will be ready to distribute in the new year. We just need to finish some technical bits to it. But what's often not taught are the actual amazing benefits of our traditional foods, and how we don't have to actually abandon them in order to have a healthy diet. And there's just a few things that we just need to be mindful of, which I will be sharing in a second. So the next slide. So this was one of the responses from our research that I found really kind of sums up what we were trying to, or what we were doing, and why it was so important. So one response said, I don't believe any one culture has the panacea for optimal health. Even the widely acclaimed Mediterranean diet, which is a diet that has been recommended in terms of having, you know, a lot of health benefits. Even the Mediterranean diet has shortcomings for some people, which is very true. And no one shoe fits all in terms of diet. And this is really important to remember, that no one size fits all, and no one has to totally abandon traditional foods in the pursuit of health. Okay, next slide. So in the absence of the fact that we don't have the African Caribbean Eat Well guide at the moment, just looking back at this guide, I will quickly, just being aware of time, I'll just quickly give some examples of where some of our cultural foods fit here. Oh, okay, yeah, where some of our cultural foods fit here. So in terms of fruits and vegetables, that's the green area. And we're talking about majority vegetables when we talk about fruits and vegetables. And this should account for at least a third of what we're eating in a day, and ensuring that we're having a wide variety as possible and as colourful as possible. And that's because the different fruits and vegetables, they contain different vitamins, nutrients, phytonutrients, and also different fibers as well, which actually help to contribute not only to health, but to a diverse gut bacteria, which supports a healthy gut, which in turn supports other parts of our body. And there's a growing number of research studies that are showing links between our gut and other issues of the body. So where we can support our gut, that would be ideal. So fruits and vegetables also include, additional to the ones that we see here, okra, pumpkin, chocho, spinach, mangoes, but this also includes frozen vegetables and fruits, and also some tinned fruits and vegetables, as long as, you know, then they don't have added sugars in them, and also some dried fruits as well, which I feel like some of us, we forget that these are also things that we can use. I know that I hear a lot of people saying, oh, I can't do fresh fruit and vegetables because they just go off really quickly. And I always say, well, frozen is great. It locks in those nutrients and it can last for as long as you need it to last. And then in terms of vegetables, so vegetables such as breadfruit, cassava, plantain, green banana and potatoes, they often fall in the carbohydrate section, so this orange section. And that's because even though they are essentially vegetables, they're eaten as starchy foods, or when eaten as part of a meal, they're generally used in place of other starches such as bread, pasta or rice. And these sorts of foods, like what I just mentioned, breadfruit, cassava, plantain, they don't actually count towards your 5 a day, but they are still nutritious and they still, do count towards your fiber intake and things like that. So it's not something that you need to abandon, just knowing that they're not counting towards your fruit and vegetable intake. So vegetables such as sweet potatoes do count towards your 5 a day because they're usually eaten in addition to the starchy food part of your meal. But like I said, they all play a role in your diet. So even if they don't count towards your 5 a day, it's best to eat them without any salt or added fat where possible. And with carbohydrates, it's best to opt for the whole grain or higher fiber versions. So Emma mentioned high fiber in terms of supporting diabetes, but it also helps to support so many other things as well. So high fiber where possible. They also help to support the gut. And that means things such as picking thicker oats versus the thinner oats. So some of the thinner oats could be Oats So Simple or Ready Brick, but where possible, just choose those thicker oats because they have high fiber and they can really help to regulate that blood glucose as well. Or whole grain rice or basmati versus the other white types of rices. And then quickly moving on to protein and dairy, just ensuring that you're opting for your lean protein sources or plant-based sources if you don't eat meat as well, or fish. And the same for dairy, so just opting for either a fortified dairy alternative. So if you are not having a dairy product, just making sure, like for example milk, just making sure that your alternative is actually fortified with things such as B12 and iodine, so that you're still getting the nutrients that you need. And there's a little purple sliver there, which basically equates to the fact that we should only be using a really small amount of oils and butters, and that's mainly because of the high energy content. So where possible, if we can opt for other cooking methods other than frying, or just using less oils when we are eating. Okay, next slide. So this is just a few things to consider in addition to the Eat Well guide. So just watch out for excess sugar and salt, and that's both in pre-made foods and the foods that we are cooking. So salt and sugar are in things that we may not even notice. So it's just always good to be mindful about this. So even some sweet prepared goods, yes, they have added sugar in them, but they also could have added salt in them. And also be mindful of seasonings, because we may be unknowingly adding extra salt to foods. So for example, I've just given an example of those curry powders. So the Bet Pack curry powder, you can see that it literally has your turmeric, cumin, coriander and things like that. But then the curry powder on the right, which I think I found on the Tesco website or something, and you can see that it has some salt in there. And a lot of us, we may not actually realize that we're just unknowingly putting, and it's not to say, it's not a blame for anyone, it's just that's just some of the seasonings that we do have, and we just don't always realize that they have added salt in them. So just be mindful of when you are using your seasonings, just ensuring that they don't have that added salt where you don't want it to be anyway. But in terms of the other spices, you can you know, I always encourage people to use herbs and spices in their food because of the high antioxidant content, which helps to prevent from free radicals, which essentially just helps to protect your cells. So yeah, you can go crazy on the herbs and spices. Just really read those labels. And it's recommended that adults shouldn't have more than around 30 grams of free sugars a day. And free sugars mean sugars that are added to foods and drinks, and sugars that are found naturally in honeys and syrups. And so just to note that 30 gram is not the aim, it's not the aim or the goal, it's just saying do not exceed this. And with salt, it's recommended that we don't exceed 6 grams, which is around 1 teaspoon of salt, or around 2.4 grams of sodium. But studies, unfortunately, are showing that we are having much more than this. So we just need to kind of know our limits and know to be more mindful of this as well. And in terms of movement, so just aim to be physically active every day. So around 150 minutes a week of moderate activity, or 75 minutes of vigorous activity a week. And I always say that any activity is better than none, and more is better still. But if you can also do some strengthening activities that work on your major muscles, such as legs, hips, your back, abdomen and chest, on at least 2 days a week as well. And 150 minutes a week roughly equates to around 30 minutes a day, 5 days a week. So just ensure that, just ensure that you are moving. Any movement is movement. You know, we don't have to go to a gym or anything, it's just moving your body. And then with stress and sleep, so really ensure that we are being mindful of our stress levels and our sleep levels, and our sleep as well, sleep quantity and quality as well. And because this can really have a knock-on effect on our health. So for example, Emma was talking about diabetes. Now, a lack of sleep and increased stress can actually increase your risk or increase your blood glucose. And the way it does that is that a lack of sleep can actually trigger a stress hormone, and also stress can trigger stress hormones. And these stress hormones are called adrenaline and cortisol. And these require a lot of energy to function and to do their function, this stress function. So the glucose that's actually stored in our body moves to the blood so that it can feed these stress hormones. And what happens is, if there's chronic stress or chronic lack of sleep, and this continually happens, and your body is continually moving that glucose from the stored area to your blood, you're now increasing your blood glucose over time. So there are just habits that we just maybe need to address, so that we are not having that knock-on effect on our overall health. And I know that some people feel that they can survive on like 4 hours of sleep and things like that, but you may not be realizing that this could be having a long-term effect on your health. So definitely get your rest and manage your stress levels as well. And also just something I didn't put down there, just ensure that you're if you are vitamin D deficient or not getting enough sun, as we are in the UK as well, it's recommended that we take a supplement of 10 micrograms as well. And the last slide, I think it's the last slide. Yeah, so I love to do myth busting. So just 3 myths that I always tend to hear. So the alkaline diet. So I will quickly myth bust this, and I hope that I won't have anyone doing the alkaline diet as well. So this diet involves only eating specific foods deemed as alkaline, and to maintain an alkaline environment in our bodies, to prevent diseases such as cancer. Now, it's true that cancer cells can't live in an alkaline environment. However, neither can the majority of our cells in our body. Now, our blood pH is around 7.4, and when we eat, our kidneys and other organs work to regulate our body and maintain that optimal pH, and any excess is passed through our urine. So the food is met with different environments before it leaves us. So the stomach is very acidic at a pH of pH 3, the intestines around a pH of 5 to 7. So the pH of that food that you are eating is actually changing throughout digestion, but our body's main concern is regarding keeping an optimal pH, not becoming more or less alkaline. Just for I'll just myth bust that one. And I promote plant-based eating, but it's just the whole notion of alkaline doesn't really make much biological sense. And then with the lemon and ginger, so nothing in a sense will boost your immune system. Just think about it more as balancing your immune system. There's a whole host of nutrients that support the adequate function of the immune system, and they all work together, such as zinc, which some people recommend taking some zinc lozenges, vitamins A to E, selenium, copper, which you can actually all just get from a balanced diet. So while lemon and ginger are great, you know, lemon contains vitamin C, ginger has anti-inflammatory properties, they're not a magic solution. And then the last one is carbs. So carbs are definitely not the enemy. They're actually our body's preferred energy source, and actually our brain's preferred energy source as well. So our brain consumes around 20% of the body's energy. So I don't know about you, but I think it will be best to give our brain what it wants. And also carbohydrates help to make the hormone serotonin as well, which is otherwise known as the happy hormone. So without carbohydrates, we're not able to make that serotonin. And also with regards to eliminating carbohydrates for weight loss. So if you have an excess of anything, whether that's carbohydrates, fats, or protein, it gets stored as fat. So, you know, a lot of this initial weight loss that we see with low carb diets is because carbohydrates, they carry a lot of water. So when you're reducing that weight initially, what you're actually doing is reducing water as opposed to the fat. So and one more thing to note with low carb or keto diets, as it's called as well, is they often can be high in saturated fat. And I've actually seen a few young people who have decided to follow a keto diet who ended up with high cholesterol, and we had to then deal with the high cholesterol. So all in all, essentially it's about having a balance, not feeling that you need to abandon your cultural foods, but also not seeing any one food as the key to health. And I think that is it. Yes, those are just some references if you needed to go back, and that's it. Thank you.
Thank you so much, Emeze. Can we please give Emeze a huge, huge clap for her time today and her brilliant presentation, because that was just brilliant. I have to say just very quickly that I have a tendency to stand in when I'm cooking to just throw all the spices into the food, just all of them, just throw them all in there. So you have given me a lot of food for thought. So thank you so much for that. Thank you. I am now going to pass over to our brilliant, amazing team member, Isaac, who is going to lead the audience questions, because we are now moving on to the audience and questions section of the event. So the audience questions and response section of the event. So I'm now going to pass over to brilliant Isaac.
Hello. There's a question which is, why is breast screening or breast cancer screening not offered before the age of 50 when so many younger women have breast cancer?
Yeah, thank you for that question. So just generally, when we think about designing screening programs, what we need to look at is the screening going to be beneficial, i.e., is it actually going to pick up what we need to pick up, is one of the questions we asked. The second thing is the method of which the screening that we do, is it going to cause harm or is it going to cause discomfort to a patient? Now, with breast cancers in particular, the risks of breast cancer are low under the age of 50, is one thing. And the second thing, the way in which we check or screen for breast cancer is by the mammograms, as I mentioned, so x-rays of the breasts. Now, actually, younger women tend to have more dense breasts, And actually it's quite difficult to read or pick up any abnormalities on a mammogram because of breast density or increased breast density. So you may actually be overdiagnosing or telling these women that you're worried about a mass or an area on an x-ray, which is actually completely normal. And of course, if you're worried about something, you need to then go on and do a biopsy, which is putting a needle in. And as I said, the majority of people who have screen are actually absolutely fine and normal. So we run the risk that if we're doing screening under the age of 50, or certainly in younger women, that we're going to put them through unnecessary biopsies basically and cause pain and harm. So which is why I say it's important that everyone, particularly those who aren't offered screening, all women should be checking their breasts regularly. And if they do have any lumps, if they feel any lumps, it's just to go to the GP, and then you can have something like an ultrasound scan, which would be a bit more sensitive. Hope that answers the question.
We have a next one. It's for Aneze, and it's, what advice do you have for those in stressful jobs regarding keeping stress levels at bay and therefore lessening the risk of diabetes? How do we convince employers to take job stress levels into account? Oh, you're on mute.
I've literally just started talking there. Okay. Yeah, that's a big question. Yeah, so the first part of that question was, how do we manage our stress levels at work? I feel like there are a few things that you could possibly do, and whilst I'm not a stress expert, I do know that just taking some time out where possible, even if it's just a 10-minute break. Sometimes some of my clients find that literally just taking that time out, doing some deep breathing. Sometimes I call it the 3-4-5 technique. So you literally breathe in for 3 seconds, hold for 4 seconds, and breathe out for 5 seconds a few times. At least then you've just been able to just have some time to breathe before you go back to your situation, and just trying to really take that time out so that you can then go back in. That's just one example. It could be just making sure that your day around work is actually planned as well, getting enough sleep, getting the right nutrients in you as well. But yeah, even talking to someone as well. So there are a few things that you can help with your own stress management. And then how do we convince employers to make it a priority? I guess it takes a joint effort, and also sometimes they might not see the benefit in it, and it's actually communicating the benefits to their employees, whether that means less holiday, well, less sick days taken and things like that. So kind of communicating how that will benefit not just the employees but the company as a whole. But that also takes it will take some work to get to, and I feel like some companies are actually starting to do it as well, because they realize, especially now COVID is here. So yeah.
There's another question here as well. How do you make your beloved curry and roti healthy?
Okay, so I have a curry recipe that I have I think I have it on my Instagram, and because so many people ask about curry, so if you are using an oil, you can use less oil. You can add more fiber in there by adding things like chickpeas, sweet potatoes, spinach. So you're increasing that fiber intake, and you can, I would always say, you can still have the spices, still have the herbs, because again, antioxidants, be mindful of the salt intake, but also leave the salt till the end. So just build up the flavors, but leave that salt till the end. And also what some people have found is that even just adding a bit of lemon brings out the salt in some of your food as well. So yes, add the salt to the end, but just add some lemon so you're building up those flavors, and then see how much salt you need at the end. So leave the salt to the end. Yeah. And then roti, you can use a wholemeal flour. You can use wholemeal flour, and I think buckwheat flour as well. Again, more fiber.
Another question is, you said that a lot of seasonings have a lot of salt. Are there any particular kinds of seasonings people should be using which have low salt? Or are you saying not to use seasonings at all?
I am definitely not saying not to use seasonings at all. I am just saying a lot of the blended seasonings, so like fish seasoning or chicken seasoning, they have added salt to them, but you can also get blends such as the Bet Pack curry powder, which does not have salt in it. And also you can actually just have the individual seasonings, such as the individual spice or the individual herb. You don't have to have those blends. You can actually make those blends yourself, or you can buy ones that don't have salt in it. So just look at the pack and just make sure that you're not unknowingly putting salt in your food. So but no, I'm definitely not saying no seasonings. I'm saying spices and herbs are great, and they season your food.
Does anyone have any other particular questions? Anything in particular? In terms of, I have a question as well, actually, for Stacey. In terms of screening, how often what's the standard timer turnaround for getting results back for various testings that you might go for?
Yeah, so standard is about 2 weeks. And the majority of the time it's via a letter, because I said the majority of people have normal results, but yeah, it's usually 2 weeks, and you will get a letter within those 2 weeks. And if you don't, just follow up with whichever, usually when they send you the letter for invitation, there will be some sort of contacts there as to who you need to contact if you haven't heard anything. But yeah, 2 weeks.
Thank you. Does anyone have any ideas what to do if your diabetes is uncontrolled?
So I would firstly consider what might be going on at the time to make your diabetes uncontrolled. So it might be that you may have an infection going on at the same time, or look at any other medications you may be taking. This is a discussion you could have with your GP. So you could book a consultation with them and discuss, you've been having uncontrolled diabetes, and your GP would be trying to elicit and find out from you how long has it been uncontrolled for. So they would be wanting you to have regular blood sugar readings that you can test yourself at home. So your GP should be able to supply you with a blood glucose meter to read your to take your readings, and you should keep a diary so you could take your you could check your blood glucose in the morning, before breakfast. You could check it at lunchtime and at bedtime, and keep a diary just to keep an eye on what your blood glucose is, and it should be in the single figures, so not 11 and above. It should be lower, but obviously not as low as 5 or less. So you should be aiming for the single figures. The GP would want to find out if there's anything else going on. They'd review your medication to see if anything's affecting your blood glucose levels. They'd as I said, mentioned, look at infection levels, and also they'll probably ask you a bit about lifestyle and see if there's anything you can do to improve your lifestyle, which might also improve your blood glucose reading. So we talked about physical activity, avoiding a sedentary lifestyle, and diet. They may also consider referring you to a dietitian or one of the education programs that I mentioned before, depending on whether you have a diagnosis of type 2 diabetes or type 1 diabetes. And if you're already on insulin, I'm not sure if you are. So yeah, someone mentioned, someone said, what if metformin doesn't agree with you? Okay, so the same person said, what if metformin doesn't agree with you? So yeah, the GP would have started you on a medication, normally a tablet if you're type 2 diabetic. So metformin is a common one. If you're having side effects from your medications, whatever medications you're having, you should speak to your GP about them so that they can either consider reducing the doses or changing to an alternative. The worst thing to do would be to suffer in silence and just not take the medication correctly because of the side effects. So if the metformin doesn't agree with you and it's giving you stomach upsets, or it's not not agreeing, the GP may need to consider an alternative, or they may, if your blood glucose levels are not well controlled on what you're currently taking, they may add in another medication. If it becomes a bit more complex, your GP may seek advice from a diabetologist, so a specialist in secondary care in the hospital. And if you are somebody who's already taking insulin, whether you're a type 1 diabetic who would be on insulin from the beginning, or a type 2 diabetic who's progressed to having to need insulin, depending on if your blood glucose levels are too high, then your GP would consider increasing your insulin levels roughly by 10% of what it currently is. And if it's too low, then they would decrease. But if your GP is having problems with managing your diabetes on the medicines that you're on, and they've tried a few different alternatives, then they probably might need to refer you onto secondary care to be seen in the clinic. So yeah, I hope that helps. Let me know if you have any further questions about that.
There's another one that's popped up. Is it a good thing to drink black tea with lemon?
If you're hoping for magical benefits, no. But if you like the taste of black tea and lemon, yeah, that's fine. Black tea has some antioxidants in them, so that's great, and lemon has vitamin C in it, so if you want to drink that, that's absolutely fine.
Someone has heard of a vegetable called chlorella, which can reduce glucose. Is this true? Is it good for hypoglycemic people?
So chlorella is a type of seaweed, and it's essentially like a vegetable that's been put into a powder. It's not the be all and end all of reducing your blood glucose alone. Reducing your blood glucose, as you've heard, it takes a multidisciplinary approach. So it's not just one thing that will contribute to it. So yeah, chlorella might be good for if you want to take it, but it won't be something that will alone work by itself.
Are there any other particular questions that people have? Just wait to see if any more come in.
I'm just responding to Patsy here privately, but in relation to this might help other people. If you've had uncontrolled diabetes for a long period of time, so 10 years or so, this is obviously based on the complications we talked about. This is something that needs to be taken very seriously by healthcare professionals. There has been a body of research that looks at poorer outcomes in Black people in the UK and around the world to do with the management of their diabetes, not being necessarily called for certain blood tests to be done, or missing screening appointments, etc. And so this is where I would say this is where we need to empower ourselves and be a bit more firm with our healthcare professional and say, actually, I would like to book an MOT with you. I've got diabetes, it's uncontrolled. We need to get on top of this because I don't want to have these health complications. So what you need to ask for is a random blood glucose, where they would do a blood test and look at your blood glucose level. Also ask for a HbA1c blood test, which monitors your blood glucose levels over the last 3 months and can see how you're doing. Now, that's normally done annually, but if you're uncontrolled and the level's still high, that may need to be done every 6 months or even maybe every 3 months to check. In addition, you need to ask them to do a urine test, which is looking for your albumin level. So albumin creatine ratio, ACR, urine test, and that will give an idea of your direction towards kidney damage. And if you're if you know, and you can also ask your GP, can they refer you on to a diabetes specialist? Because if they're not able to manage your normally diabetes can be managed in the community by the GP in primary care, and if it's not being managed in the community, they need to seek specialist advice and see if there's an alternative. Unless it's the fact that you're not taking the medicines as it's been prescribed, if you are taking them as it's being prescribed, and the GPs, they've tried a few different regimes and it's not quite working for you, then they need to seek support. It's not good enough for it to be uncontrolled for 10 years. Does that make sense? So I hope that helps. But just be firm with that. And when you do go to your appointment, whether it be with your GP or your the specialist in secondary care, make sure you have a list of medications that you're taking. Make sure you're keeping a diary of your blood sugar levels throughout the day, at least 3 times throughout the day. Make sure you are testing that yourself. Make sure you have adequate test strips with your monitor at home. Yeah.
People have mentioned, can you reverse diabetes? And you mentioned, when you spoke about reversing diabetes, could you explain how it works again?
So it depends on the type of diabetes that you have. If you've got type 1 diabetes, that can't be reversed as far as I'm aware. That is no insulin production from your pancreas, and that would be the complete loss of the cells that produce the hormone insulin. So that those patients would automatically be treated with insulin, and that would be an ongoing treatment for them. But for those who have type 2 diabetes who develop it over time, usually older than 50, but some people can develop type 2 diabetes at younger ages now. So we're seeing a lot of young people with obesity and developing diabetes. Traditionally, diabetes was like you'd see type 1 diabetes in younger patients and you see type 2 diabetes in older, more obese patients. Now you're seeing younger patients with obesity, they could have type 2 diabetes, and you could see someone who develops diabetes over 50 who might have type 1 diabetes or another rarer type of diabetes. But in type 2 diabetics, there is a study that's happening called the DIRECT program, and they're looking at reducing the calorie intake for these type 2 diabetes patients, whether it be through certain foods or low calorie shakes. And the main aim of the treatment is weight loss. So often these patients, and obviously that would mean the person would have been overweight to begin with. For type 2 diabetics who are not obese and not overweight, this program or this method probably won't work because they'll be losing too much weight. But some of these patients have lost probably roughly 2 stone in weight. And how that works is, we talked about type 2 diabetes having 2 main ways in which it causes the increased level of glucose. So one of the ways is what we call insulin resistance, where the muscles and fat cells in our bodies don't respond to the action of the insulin hormone, which is telling the cells to open up and take in glucose to therefore reduce the level of glucose in the blood. Insulin resistance is one mechanism, but it's not by itself. In type 2 diabetes, there's also a reduction of the production of insulin, because either the beta cells in the pancreas that produce insulin are not working, or they're being destroyed over time. So this method of diabetes remission uses weight reduction, and in that process the fat levels around the liver and the pancreas is reduced, and the body starts to respond much more better to insulin that is being produced. And so they're seeing that many of these patients who are on a low calorie diet and having weight loss are no longer requiring the insulin or the medications to lower their glucose levels. So i.e. what's happening is, by diet, in effect, their glucose levels are becoming normal, and they're not needing to give themselves medications to lower the glucose. So that's how it works. And the good thing about this is that it's showing that these patients are having a reduced risk of the complications I talked about earlier.
Would you say that diabetes is nature or nurture?
It depends which type of diabetes. So I mentioned that there's 3 main categories of diabetes. There's a type 1 diabetes, which we know is an autoimmune disease. So the body is fighting against itself. So often people with type 1 diabetes have a relative, a first degree relative, who also has type 1 diabetes, whether it's their mom, their dad, their sister, their brother, etc. Type 2 diabetes is a combination of both environmental factors and genetics. So we know that the risk factors for diabetes, and in particular type 2 diabetes, includes the modifiable risk factors that we can change, such as obesity, high blood pressure, and a sedentary lifestyle. But there's also the non-modifiable risk factors that we cannot change, such as our ethnicity, which involves genetics, also age, and I think there was some another non-modifiable risk factor. So it's a combination of both.
How do you go about reassuring some of our elders who may be afraid to go out for screenings because of the fear of contracting coronavirus within a health setting?
That's a very, very good question. Firstly, to say that, well, firstly, things like the bowel cancer screening is a home testing kit, so that's quite easily sort of done. You don't need to come into the healthcare setting. Things like cervical cancer for those over the age of 60s, again, it's done at your local GP surgery. And I think the local kind of units will advise you in terms of, they have their own ways of kind of reducing COVID and the precautions that they have. So of course it's about wearing your mask, it's your social distancing, it's possibly about not having many people in the waiting rooms, and therefore you not sort of waiting for too long when you're booking your appointments for that. What I would say is, if you're invited and you're worried, then please contact the screening team, because again, it is about just picking up, trying to pick up any things before it becomes something, basically. So it's not as if it's a you have a problem and it's a health checkup that you need to see someone for. So if you are really concerned, maybe you're shielding, you're really worried about your risks because of other underlying issues and your risk of catching COVID, then just speak to the screening team, let them know, and then they can make certain adjustments as well for you to make it sort of COVID safe. But certainly don't ignore letters. You can, rearrange appointments when things are at a better time, but certainly don't ignore letters and not go for screening because of that reason. We are still open, the precautions are there, and just speak to people and just let them know your fears.
Just seeing if there are any other questions. What's a good way of getting, I guess, elders in the community to be, I guess, more active? So I've been around people who have said, I'm not diabetic, I was pre-diabetic and now I don't have it anymore, not realizing that neither of those situations are good to be in the first place. So how do you convince people that you're not better than someone else? You should always trying to do particular things to help yourself. How have you found effective, tools in convincing people either within family or the community that you're around to get them to be more active, to take their health a bit more seriously?
I think, sadly, like my grandma would say, if you can't hear, you will feel. And it's sad to say, but oftentimes in our community, it's when we see something happen to someone that's quite sad that we realize the impact of not acting on our medical conditions and our health earlier. So often the sad thing about diabetes and high blood pressure, these are serious diseases, but often can be asymptomatic. So there's often people may not experience symptoms, particularly in type 2 diabetes and high blood pressure as well, unless it's really high. And so that may lead many people in our communities to feel that they don't need to take the medications that were originally prescribed. In the UK, you pay for your prescriptions, but it's not necessarily, it depends how many prescriptions you're having, but there may be exemptions. So we have benefits like in the UK that can help, I don't mean like there are the benefits program, but there's also we can benefit in the UK from having maybe cheaper prescriptions, free hospital visits, although we do contribute to in our taxes, etc. In other countries, like in the Caribbean, it can be very expensive to manage your health conditions. But talking about in the context of the UK, we are so blessed that we have access to these screening programs, to diabetes health checks, the eye screening, the foot screening. There's no excuse for us not to take them up and to take ownership, to keep a diary and know when our next appointment should be and attend them. For those who are borderline or pre-diabetes, I think the word borderline and pre-diabetes can give a false sense of security. And so it's important for us to be aware of the end stage, the worst case scenarios of where we've seen family members who've ended up with amputations and sadly passed away not too long after that, or family members who didn't manage their high blood pressure very well, and then they quickly became unwell and were diagnosed with end stage kidney disease, needing dialysis. And this is where we need to just remind our family members and have these conversations to say, you know, if you don't look after this, sadly it could get here. And I don't want to make it a doom and gloom conversation, but it's important we are aware of the realities. So if somebody is in the pre-diabetes range or borderline, what they should at the very least have is ask their GP to put them on the pre-diabetes course, which will give them the education required, just kind of like what we're providing today, but it's more intensive and focused on pre-diabetes and how to prevent diabetes. That will give them the information so that they know how to change and alter their lifestyle to prevent it becoming diabetes. So I think that's the key thing, is education, and for us in our communities is discussion. But we need to be more assertive when it comes to our GP appointments and asking for things, and but in order to ask you need to have the knowledge and a bit more education. So now you know about there's a pre-diabetes course, you can ask your GP. If you have any of these symptoms, you can ask for a blood test. And there's no reason why your GP shouldn't be able to do the blood test, particularly if you've got a family history of diabetes, or you're at an older age. And even if you're a younger age, the GP can do these blood tests and diagnose you, because diabetes can affect anyone from baby all the way up to, you know, in your 80s, as we've heard today. So, yeah.
And just a note on the pre-diabetes course. So before you had to only be referred by your GP, but now I think they've just changed it where you can actually self-refer from a website, and I can't remember the website, but if you just type in like pre-diabetes, National Preventing Diabetes or something like that, you can self-refer now. So even if you don't have pre-diabetes and things, so.
Thanks for that, Anessa.
What can people do to, oh my gosh, the question just disappeared. What can people do to reduce kidney failure?
So kidney disease can be have a number of causes, but if we're talking about in the context of diabetes, we know that diabetes, the end result of having diabetes and high levels of blood glucose and the processes around the diabetes disease process is that it results in inflammation, increased free radicals in the body, and it affects the vessels, so the large vessels and the small vessels. So in the case of kidney disease, it's affecting the small vessels in the kidney, and what we need to do is monitor the process before it gets to end stage kidney disease. So a diabetic should be having a urine test called a albumin creatine ratio, ACR, and it looks for the micro levels of albumin in the urine, and less than 30 is in the normal range. However, if that is monitored annually, if we were to see that level increasing over time, that would be an indication for that diabetic, or for the GP looking after that diabetic, that they are on the road towards kidney disease. So in terms of reducing kidney failure in the context of diabetes, it would be to have well-managed diabetes. So you'd be aiming for a HbA1c blood test between 48 and 53. Again, I mentioned before, we don't want that HbA1c to go too low, because that puts a diabetic at risk of hypoglycemia, which can be life-threatening. But we want to make sure that the diabetes is well controlled and well managed. So a diabetic would know that by doing their blood glucose levels at home and keeping a diary of that, but also making sure that they have annual or 6 monthly HbA1c blood tests with a GP to make sure their diabetes is well controlled. If the kidney disease is related to high blood pressure, again, it's to do with making sure your blood pressure is well controlled. That's another talk altogether, so I won't even delve into that, but yeah.
Are there any other particular questions that people have? One more question. If anyone wants to put one into the chat. Okay, so are you saying if one does not take their high blood pressure medication, it could lead to kidney problems too?
Yes, Trey. You know, if the high blood pressure is not controlled with your blood pressure medications, it can result in damage to the kidney, and people with high blood pressure may not realize that until serious events such as kidney disease, which can be detected in a blood test, or even other conditions such as stroke. So I'm not sure if you've got high blood pressure, you should purchase a high blood pressure monitor to take your blood pressure at home, and keep a diary of what your blood pressure is like in the morning or when you have symptoms, or and in the evening. It doesn't have to do it all the time forever, but you could do it for 2 weeks, for example, and book an appointment with your GP and discuss your readings. And your GP will be, if you don't know what the normal blood pressure reading should be, your GP should be able to discuss that with you. But not taking your high blood pressure medication and your GP doesn't know about it is not a good idea, because high blood pressure doesn't have any symptoms unless it's really, really high. And so what we want to avoid is these long-term complications that would be difficult to reverse. Yeah, I hope that answers your question.
Thank you. Oh, and one last question because it's important. How do we know if a health message that's been sent on WhatsApp is true or not? Because I've seen this a lot with family and I have to debunk them and it doesn't work. So how do we know if it's true or not?
Okay. Check the sources, ask a professional as well. That's why I'm always on my Instagram debunking myths. And I get a lot of these questions and a lot of these WhatsApp messages sent to me as well. So check with, if you do know a health professional, I'm happy to also take any of these WhatsApp messages because a lot of them do get sent. But yeah, check the source, check where the research has come from as well. And if you don't know how to do that, just ask an actual registered professional.
And also, if you,
go on.
Can I just add as well, like, say for example, you don't have Ameza's personal number to do it, send her a WhatsApp message. You know, the government has set up, there's a NHS website which has information on pretty much all the different health conditions that you need to know about at a patient level. And also there's also the patient.co.uk website, which has information for healthcare professionals at that level and also for the general public to understand health conditions. So rather than just going to Google and looking at any article that comes up or any YouTube video, those websites are very helpful in giving you information about conditions. So yeah, I would advise those two websites. The NHS, you can type in a health condition and afterwards put NHS, and then you'll get the NHS website about that condition, or you could type in the health condition and say Patient UK.
Brilliant. Thank you so much. I just want to thank Dr. Blake, thank Dr. Brian and Ameze for their wonderful contributions. Can everyone give them a wonderful applause? It was amazing. Thank you so much. Yes, thank you so much for sharing information, because it's necessary for people to understand, certain things about complex health conditions, which obviously take you a long time to study and learn about, and obviously for people to deal with when they have them themselves. Obviously, I'd like to thank everyone in the Caribbean Links team, Afia, Marcy and Stacey, for their help in supporting the event together. And you can follow us on Instagram at Caribbean_links_group, and on Twitter at Links Caribbean. I'll put that in the chat just now. And we will have our next virtual event, which will be a Christmas party, and it'll be on the 23rd, which is going to be quite exciting for everyone to have a bit of fun and cheer. But thank you everyone for joining us this evening, and we'll make sure we put this event up hopefully on our YouTube and website in due course. So thank you so much, everyone.
Thank you so much for that, Isaac. Thanks so much. And thank you all so much for answering for those brilliant questions and the questions that were answered. Thank you, Dr. Stacey, for the great talk about screening. Thank you so much, Dr. Emma, for talking about diabetes, and thank you so much, Emeze, for talking about diet and lifestyle. Again, thank you all so much for coming. Thank you to the brilliant panelists. Thank you all so much for your time. Thank you to the brilliant Caribbean Links team, as Isaac said as well. Again, I get a lot of help from the team. I don't do this on my own, so thank you all. Yes, that is true. On the 23rd of December, get ready to walk up. It is going to be the Caribbean Links Christmas party. It's been a really rough year for so many people, so we just want to have a bit of fun, and we'll provide you with more details of that. Also, if you could scroll up to the top of the chat, our brilliant Caribbean Links team members and also our brilliant panelists have put some information about further information about the different projects they're working on, so you can click on their websites. For example, Isaac is co-founder of Black Men in Law, and he's put details at the top, and so many of our other panelists have put details at the top as well, if you would like to check out what they do. And again, our social media Caribbean Links handles have been posted in the chat box, and I think that the British Doctors and Dentists Association social media handles have also been put in the chat as well. So again, thank you all so much for coming, and we will see you soon. Thank you, everyone. Bye, and have a lovely evening. And as our brilliant panelist Stacey said, not everything that is faced can be changed, but nothing can be changed. Well, to quote James Baldwin, not everything that is faced can be changed, but nothing can be changed until it's faced. Thank you so much for that brilliant quote, Stacey. Thank you all, and have a lovely evening. Bye, everyone.